What's up today, guys? I'm back teaching a PCCN refresher course before these nurses are going to take that certification. Now, I'm specifically talking about arterial blood gases and the pulmonary system, some different things you want to look at with the COPD patients, and a whole bunch of other stuff. So, put on your seatbelts because we're about to cut to the intro. So this is real similar to this, probably the same place that I go to take a test. So the cool thing about this is that you get an appointment time, you go in. Is this where they take everything from you, give you a pencil?
Yep.
Okay, so don't be freaked out if you haven't done this for a while. Don't be freaked out if the whole room's full and you're the last one left. Because this is what I've did, because I've taken probably 5 tests at these places. Some people are taking a realtor test, some people are taking landscaping tests. Not everybody's taking the nursing test. So when you're in your zone here, I always get earplugs. I put earplugs in. I go because they give you a set. I put earplugs in, go into my zone, and you're allowed to cover and take a break at certain times if you need. You shouldn't need to with your length of test. But if you lean back or something and you stretch and you're like the corners of your eyes, you see like people gone, you're the last one there. Don't be freaked out. I always say, that's just a realtor test. It's probably like 3 questions. I'm sure it's way harder than that. But it seems like the medical tests always take way longer than they should. So don't let that kind of get in your head because it can, definitely. And I always like to come at these tests with almost, you can come at them defensively or come offensively. So I like to come at them offensively, where I know this sounds kind of weird, but I'm like going to attack this test. All right, so this test is going to be done by the time they're going to try to throw everything they can at me, but I'm going offensively at it. And I think if you keep that kind of thought during it, it helps quite a bit instead of and that will keep you from getting a question like Josh has like with OB, and you're like, oh, that's like one punch in the gut, and the next one another punch in the gut, and you don't want to get down with that. You say, take this question, okay, I probably bombed that one. Start new the next time, and that's what all these medical tests are kind of about. So that's one encouragement I can give you with it, because I know I ran into the same thing. We used to have a doctor disagrees thing. Doctor disagrees, doctor disagrees, and they've told us before with the respiratory stuff that doesn't necessarily mean it's wrong, but they're just seeing that they can throw you off the game a little bit, just like that's probably more like your NCLEX type stuff. But I did take some of these questions too. I like these questions because it's recall. A lot of it is recall. So they give you some kind of disease and they give you some options. You're like, this is the only thing that it really sounds like a good treatment for this type of disease. So there's a lot of kind of recall stuff in there. Not a lot of super deep things. And like Josh said, I think they, NCLEX, you probably have like 3 really good answers, one that's really far off. I think in this case, usually there's 2 of them, and usually it's pretty easy. As soon as you read through it, you're like, that's it. So that's a good thing about the test. So 17% pulmonary. In the practice one I took, the first part of it was a lot of pulmonary. I don't know if this is the way they did it, but ABG interpretation. So it's something that we're blessed here that you don't have to do. We have a lot of blood gases, but as a most part, we have a lot of therapists that can just like, hey, okay, this is it. And they probably bring a BiPAP with them, and you're like, oh, it must be what they need. So you don't have to get in a lot of real deep part with ABGs. And the great thing with this is it's not really deep in ABGs. You gotta see a couple different things. So I'm trying to look at an ABG. First one's ventilation, the second one's oxygenation. We always fix ventilation first, because usually if you fix somebody that's not ventilating, then you'll fix their oxygenation problem. So first thing, when I look at a blood gas, I go through, and if I'm treating it, I'm going to go ventilation, oxygenation. Actually, in respiratory therapy school, we go ventilation, oxygenation, circulation, perfusion. So that's kind of our thing. So if they give you this blood gas, it's like everything's wrong with it. Okay, the first thing I do, fix their ventilatory problem. So let me just give a quick rundown, because I do know that there was one question that actually gave the whole So you gotta name blood gas, which is like not super fun, because you're like, oh, I don't remember this. I know how to treat it, but I don't know how to name it. So this is the little short version of what I give the nursing students before they take their blood gas exam. So first you gotta know your normal values. So you guys probably know these already. What's the normal value for pH?
7.3.
Yep, 7.35, 7.45. Okay, we always do PaCO2 next, the little a next to it. I don't think they'll do this to you. PCO2, P little aCO2 is the same. That just means arterial. So the arterial pressure of CO2, what's normal for that?
35 to 45.
Good. So it's right here. Okay? So that just comes right down. And that's millimeters of mercury. Now, I'm going to put PaO2 on here. It's 80 to 100 on room air. And it definitely changes when you add oxygen to them. And they may give you that aspect, but has nothing to do with acid-base balance. So nothing to do. If you change somebody's oxygen, it will not affect their CO2. And we get that a lot. Well, I'm not ventilating, let's turn our oxygen up. Well, that's not really the problem. Ventilatory is the different issue. So the last one is HCO3. So bicarb. What's normal bicarb?
23 to 29.
Yeah, it's really close. I think you're thinking of CO2 on a venous blood, which is very similar. So if you get morning labs come up and it says total CO2, I think it is 22 to 29. Now that's venous bicarb. Arterial bicarb is a little different. 22 to 26. Okay, so that's the normal for that. Venous is a little different. You're going to have a little bit. It's just going to change a little bit. But with arterial, it's 4.5. So what you have to know is when the pH moves, what's causing the problem, and are you getting help from the other system? So if we're gonna just do a quick rundown of how to read these. Now, tell me if this is not what you want. Okay, are you good with doing this now? Are you guys feel good about reading them? Because I can mold this class to you. So
This is what I need help with.
Okay.
Yeah.
Okay, good. Okay, we'll spend a little time with it then. I'm going to give you the same way that I give the students. All right, let me explain this all now. Okay, so every blood gas is named with 3 names in all these cases, and we read them all backwards. Every time we read it backwards, so we're going to say acidosis, alkalosis first, metabolic, or respiratory. So that's what we're blaming it on. And then we're going to call it compensated, uncompensated, or partially compensated. So that's a lot of information, but I'll show you how to do it. So if we're going to go, and I give you a blood gas, okay, so this is for shorthand for a blood gas, 732, 53, 80, and 24. Okay, so pH, CO2, PO2, bicarb. So the best thing to do to name a blood gas, and a lot of people can look at this and say this is uncompensated respiratory acidosis. That's good. If you can do that, that's great, but sometimes you don't see these every day. So the methodical way to read them is to go through each one of these and call it acid, alk, or normal. So you're going to go through each one. If you know this, you can do this, because we know that below 735 is acid, right? Below 745 is alk, or basic. A CO2 of 30, does that cause acidosis or alkalosis? Your CO2 is low. How does your CO2 get low?
Hyperventilate.
Yes, you're breathing too fast, so you get alkalosis in that case. Okay, so below 35 is alkalosis, above 45 is acidosis. Now, I know you guys know this one. A bicarb below 22, is that acidosis or alkalosis? So if somebody says our patient has a bicarb of 10, acidosis, right?
They're blowing off.
Well, no, your bicarb is related to your kidneys.
Okay.
Yeah, so your bicarb is related to your kidneys. So down below 22 is acid, above 26 is alk. This will make sense in a second. Okay, it's a lot of information. So let's go through this, and if you get nothing else, to know this is really important, because you can kind of muddle your way through the blood gas. So let's go through. 732, is that acid, alk, or normal? Acid. Okay. CO2 at 53, acid, alk, or normal? Acid, good. This is normal. 24 bicarb.
Normal.
Okay. Whatever reads on this side, on your pH side, goes right here. Easy enough, because it's an acidosis. Your pH is kind of like it's balancing these two different entities, and it's going to tell you are you acid or are you alk. So whatever your pH says goes right here. So this goes acidosis. All right. So next thing is when we read them backwards. So we need to go backwards. The next question is going to be respiratory or metabolic. Well, this comes down to which system do we blame it on? So which one's out of whack? Is it the respiratory system or is it the metabolic system? Or make it easier, whichever word matches your pH. So if your pH acid, your CO2 is acid, so that's respiratory, because CO2 is respiratory, and my bicarb is metabolic. Okay, makes sense. Your kidneys take care of filtering, and your lungs take care of your ventilation. So these two match pH, so we call it respiratory. All right. So this is methodical. I know it takes a little bit of time, but it's methodical. So the next thing is we have to look at the last part. Now, does anybody have a problem with those first ones we did? Okay. So you see it's an acidosis because your pH is acid. You see that your CO2 is high, so you say it's a respiratory acidosis because they're both acidoses. And then now we need to go, and the question you ask yourself here, which is usually where most people have the problems because there's like so many different things. And Ivy Tech used to teach compensated, uncompensated 4 years ago and before. And in the last 4 years, they're doing compensated, uncompensated, partially compensated. This is where it gets a little funky.
So if the CO2 was alkaline,
Yes.
it would be metabolic?
Let me give you another, I'll give you another one.
Okay.
Yeah, because you talking about bicarb or are you talking
Because
about?
you said if they match, it's respiratory. But if
Well,
they didn't,
if they match, no, don't worry about that. Whatever one matches what your pH is. So if this was normal and this was acid, it would be a metabolic acidosis.
okay.
So whichever one matches your pH is really your big indicator. This part right here, compensated, partially compensated, or uncompensated. So the question you ask yourself here is, are they getting help? Is the system doing what it's supposed to do? Because if your CO2, your respiratory system starts to fail slowly, your bicarb slowly creeps up. So you got acid over here, and your body senses that, so your bicarb climbs into the alkalonic and then offsets it. So that's your compensated people. But you need to ask yourself, right now we're in a respiratory system as an acidosis. Are we getting help from the other system? Which means, are we getting help from this guy over here? Are the kidneys helping? In this case, if this remains normal, this would be uncompensated. We're not getting help, okay? So uncompensated respiratory acidosis. A lot of information. Let's do another one, okay? We've got a bunch of examples of this. So, the only way, and I'm going to say this one right here, this is the caveat, the only way to be compensated or fully compensated is to have a normal pH. Okay, so that's the only way to be in there. Let's go to the next one. Let's see the whiteboard too. Erase as well. Okay, next blood gas. 7.15. 29, 95, 15. This is kind of a mess. So it has a couple like critical values on it. We'd probably call you and say, hey Chris, this has critical value, I need to report this to you, and we put it on our blood gas machine. But it looks like a mess. but let's do a quick read on it, okay? Just to find out the cause and give the cause for it. So, acid or alk? Acid. Acid or alk? Alk, right. So, what does somebody look like from the door if their CO2 is 29? Their CO2 is low. So there's two things to get your CO2 low. Your tidal volume and your respiratory rate. So they can be doing this. Maybe 16 or 18 a minute, but their chest excursion's big. And that's how you're going to notice it first, is their chest excursion's going to start getting larger. And then you're going to notice the respiratory rate. And now that's not them freaking out. That's their brainstem saying, breathe faster, get your CO2 down, because we're sitting in this acidotic state. So this is normal. What about our bicarb? Acid or alk? Acid. Okay, we've got that. So we take whatever the pH says, we put it right here, acidosis. And then which one matches it? Because that's where we have to go to here. Which system matches it in this case? The metabolic or the respiratory? Metabolic. Okay, good. So now, the next question we ask, are we getting help from the other system? Does the other system do what it's supposed to do? Yes, good. It is. So we know it's not this. We know it's not uncompensated. And then we're down to these two. Is it fully compensated yet? No. So there's one other option. Partially compensated. So this would be partially compensated. Metabolic acidosis. So that's what's going on in this case. This might be easier for you, since you guys are clinical people. Give me a disease process where you might see this. Metabolic acidosis. There's three biggies.
COPD?
No.
No.
Not usually.
Okay.
Metabolic acidosis. So what's causing the acidosis is metabolic. We think about kidneys. So one of them is renal failure. Renal failure is a biggie, okay? A biggie. The next one is a disease process where they're going to have really specific breath sounds during that time. Breath sounds, a respiratory pattern during that time. It's going to be like this. It starts with a K. Actually, on this test, they talk about respiratory patterns. Kussmaul's. For Kussmaul's respirations, you're not. It starts with a K. Also goes with the disease process, which is DKA. So, metabolic acidosis, the three big ones I teach. DKA, which you guys will figure that out. I mean, you'll figure that out when you do blood sugars on people, like we're giving out glasses of water. So, blood sugars, we're going to see that already. You're going to know that in your patient. Your renal failure patient, okay, metabolic acidosis. And your third one is a little more occult, and so it's going to be a little more difficult to find, but it's your septic patient. So when your patient becomes septic, they'll start releasing lactic acid in their system. And the way you'll know they're septic, the first way you know they're septic before anything else, is the PCA is going to come to you, and you look at the respiratory rate, and be honest, 16 is a really good number. All right, so respiratory rate, 14, 16, 18, 20 is like, nah. So you always should count respiratory rate, but it's really important in these cases where you suspect this, because the first way that you'll see a sepsis in some cases is respiratory rate was 14, 16, 18, and now it's 20. You'll see a slow increase in a trend. That means their brainstem saying, we gotta get our CO2 down. Because that's what the brainstem says. If the brainstem senses acid in the arterial blood, it's got one fix for it. Breathe faster. Brainstem isn't like, well, this is a respiratory acidosis, so we're gonna do this. Or it's a metabolic acidosis, we're gonna do this. No, acidosis, breathe faster. Doesn't matter if it's respiratory or metabolic. That's what it's going to trigger you to do. So the respiratory rate increasing means there's an acidosis of some kind. So you just got to figure out which one it is. And you sometimes know by history. So, partially compensated metabolic acidosis. Let's do another one. We get a lot of blood gases like this. We do them, let's say it's, we do pre-op gases, so if they're gonna have open heart surgery in a couple days, and they'll come in, we got to do plug gas on them, which is great. Because it's like, oh yeah, you're gonna have a line when you come in, but right now you don't have a line for this. So we draw blood gas, we get a blood gas like this, we send it through the system, anesthesiologist looks at it, it's like, yeah. You know, they're not gonna do any changes to their course of treatment with this, but this blood gas isn't normal. So let's go through it, and we'll just kind of mark what it is. So, acid or alk or normal? Alk. This, acid, alk or normal? Okay, normal, acid, alk or normal? Normal, still normal, okay. So, alkalosis, it goes all the way over here. Which one matches it, the respiratory side or the metabolic side? Respiratory side. Does everybody get that?
Mm-hmm.
Okay, that's good. There's always somebody that doesn't get that in my nursing classes. It's really weird. There's always like usually 2 or 3 people. That's okay. Respiratory acidosis. Now the next question is, are we getting help? This guy helping?
No.
No. Uncompensated. So I hand you this blood gas, Vita. Say your patient is an uncompensated respiratory alkalosis. And you're like, oh, whatever, Jimmy. What are you gonna do? Nothing. Think about what causes you to do this. Take about 3 extra breaths a minute. Does it hurt to have your artery stuck? Yeah, from what they say. Not always. I always say the nurses are gonna hurt you way more. That may not be true. So I go, but it does hurt. So if I take 5-6 extra breaths, it can get my CO2 down to 31. And then your system's gonna go, whoa, it's gonna kind of be whacked a little bit for a second. But this is uncompensated for alkalosis. When the rapid breathing stops, my CO2 will go to normal and everything will be great. What if a patient comes in the ER, they have this. Okay, so let's say they broke their hip, broke troche. Okay, so they have a broke troche and they're in the hospital. Maybe they're not on your unit, but they have a lot of pain. They come in, they have this blood gas. Like, okay. So, but their respiratory rate, you're continuously documenting 20, 22, 24. It's up there for a long time because pain is not under control. What's going to happen to the body? Now, this is where it all comes together. What's going to happen to the body when somebody breathes like this for 6 hours? So you breathe at the respiratory rate. Chris, you're healthy. So you breathe the respiratory rate of 24 for 6 hours. What's going to happen to your blood gas over time? What's the body's natural reaction to it? So if your CO2 maintains 31 and you maintain this alkalosis, how does the body get help?
To compensate.
Compensate by doing what?
Changing the bicarb.
Yes. Which way? Up or down?
Give me 1 second.
It's okay.
Down.
Down. Good. So it's going to go into the acidotic range. It's going to go. And it's got to get down there below, probably about 20 or so. And once this starts to go down, as this goes down, your pH will start coming down to normal. Okay. So then, if you got somebody that's hyperventilated for 6 hours, so bicarb moves slow in every case except for if you code. That changes really fast. But if you're living, it moves very slow. CO2 moves very fast. So if we're looking at things that happen fast, it's usually with the CO2. If we're looking at things that happen slower, it's the bicarb. If they both worked fast, we'd be a hot mess, changing everything else going on. One of them's got to be slow, one of them's got to be fast. Okay, so this would slowly go down. You're right, and because the body's goal is 7.40, right in the middle. 7.40. It will it will mess with both sides, respiratory rate, and it's doing this all autonomically. It'll mess with the respiratory rate and try to get this all to normal. So, after saying that, the next blood gas. Bit extreme, but that's okay. But I'm gonna get on the phone. I'm gonna say, I have a panic. Thank you, nurse of this patient. I have a panic CO2 of 96. CO2 is over 60. We have to call. And I just want to let you know that, and then hang up. And you'd be like, okay, you're not gonna be over to do something, man, because it's called me a panic value. This is panic value. But let's read this blood gas, okay? Oh, you're good. You're good. Let's read the blood gas. So 7.38 is acid, alk, or normal? Normal. Good, good. CO2 of 96, acid, alk, or normal? Acid. Super acid, right? This is low, normal, lowish. It's PO2, so don't worry that much. It doesn't mess with that. And this is alk, big time, right? Well now, Jimmy, where in the heck, what do we do now? Because this says normal, and this is not a normal blood gas, right? I know this could be something on your test. So this one's pretty common. So we have to go by, and this is where it gets funky. Which side of 7.40 are we on? Acid. Then what goes here? Very good. Everybody understand that why that is? Because that's acid too. What goes here now? Fully compensated. Yep.
Yeah.
I'm sorry. Fully compensated. Yeah. I should put fully. So, because pH is normal. Fully compensated respiratory acidosis. Does this person need help right now? Not by their blood gas. Now, if they're working to breathe to maintain this, yes. So the outward signs and symptoms, we could address that. But if they're not having any difficulty right now, this is normal blood gas. This is the difference. We get this all the time in the ER. And this is the blood gas, it's really not this bad. And they say, then you put a BiPAP on them. Like, well, their body's doing pretty good. I mean, you don't get to a 51 bicarb without having your fair share of Marlboros. Okay? It takes a long time to get to there. It's not all Marlboros, but it's some kind of obstructive lung disorder. So it takes a long time to get there. What's going to happen when I put somebody on BiPAP with this? It doesn't necessarily hurt them at all, but it's not a great way to treat the blood gas. So what if I put this patient on a BiPAP? What would happen to their CO2? Start going down, and they're actually going to go alkalotic until this thing comes back down with it. Now, that's slow too. They'll be slow to catch up. But this is a normal blood gas for a COPD patient. So, how do you feel about this? Do you want some more examples? What do you think?
I need more like clinical symptoms, like walking into the room. Like what matches that blood get? Like that's what I have a hard time with.
That's okay. Yeah, that's okay. So alright, let's change it up a little bit.
Like if they give us a clinical example of a patient, what do you expect their blood gas to be?
Oh, okay. Okay. Let's look deeper into this one. Now, this probably won't give you one this tough, but I want to give you just so you get an idea. Let's change this. Okay, so let's do this blood gas first of all, and then you tell me what you think's going on with it. Okay, so from the door, Josh is the patient. From the door, the patient has an increased respiratory rate. I know they're on treatments Q4, and I know that they have COPD, and they've had it for a long time. They're on 3 liters of oxygen at home, and they've been doing well. they had an exacerbation a couple days ago, got it under control, they're nearing discharge, but I walk in and I notice they're just, look like they're working a little bit to breathe. So I go in, you talk to them, you ask them, are you having shortness of breath? Yeah, I'm just feeling more short of breath than usual. And you say, well, they don't look real good, let's do a rapid response. We do a blood gas, here's the blood gas. So let's look at this one real quick. This is a little funky one. So this is acid. This is acid. This is normal. And this is alk. Okay, so acidosis. Which one matches it? Respiratory. And what do we put here as far as your compensation? Partially compensated. Because we're trying to get help, but it's not enough. Tell me about this patient with COPD right now. Do we need to make an intervention?
I would think something, if they're struggling to breathe.
Okay, struggling to breathe is a good hour symptom. Yeah, that's a sign, right, that they're short of breath. That's one reason. But by this blood gas, if you didn't have that, would you make an intervention by this blood gas?
No.
Tell me why.
Because if you put more oxygen on them, it's gonna hurt. Like,
Yeah, so I wouldn't, so don't even take the oxygen part into it. Because oxygen is like, you know, it's this one right here. We're not even looking at it, we're looking at ventilation, so we're looking at CO2. So I think they need help by this blood gas, and I'll tell you just why, because you're acidotic. You know, you are out of normal range right now. If you're out of normal range, the body's not doing what it's supposed to do, so we need to help them. So yeah, they have the outward signs, and their pH is out of range. So definitely you need, it's indication for a BiPAP. And if they're working really hard, we can use a ventilator. I don't want to skip all that kind of stuff. So let me take this blood gas here, partially compensated respiratory acidosis, and now let's talk about treatment. Now here's the deal with this one. Bicarb's 30. You know that they're already a CO2 retainer because their bicarb's 30. They probably sit like that at home. But right now, this is what we would call acute on chronic respiratory failure. So they're failing right now, but they really have chronic respiratory failure. Once their CO2, once their bicarb goes up out of normal, they're chronically respiratory failing. I mean, you could say that, but they're acute on chronic now. So let's talk about a treatment for this person. So we have 3 options that are on your list here. Well, we have multiple options. Okay, BiPAP, CPAP, it says face mask. I'm not gonna put that on there. Face mask. High flow cannula. We do a lot of these right now, right? It's kind of confusing. Regular nasal cannula, non-rebreather, NRB, and a Venturi mask, Venturi mask. Okay, those are our options for treatment. This is what we have available. In this case, what do you think would work for this patient? BiPAP. Because this is the difference. This fixes both of these issues. These only fixes oxygen issues. Okay, so that's the reason you see some people on BiPAP is because, for one, BiPAP has the option, if they're not oxygenating, we can fix that. But if they're not ventilating either, we can fix that. It's kind of the 2 for 1, and if we're not for sure, and Chris comes in and she's like, I'm on some kind of thing at night when I sleep, and I'm not sure what my settings are, and blah, blah, blah. It's probably CPAP, but we'll probably just put you on BiPAP because we don't know. Because BiPAP actually will take care of both of those issues. In this case, this is a ventilation issue, so we're going to put them on BiPAP. So let's talk about how BiPAP works real quick, and then we'll get into these other ones. So, BiPAP stands for 2 PI PAP. So 2 pressures, positive airway pressure. So the best way to look at it, has anybody ever worn a BiPAP before? Should have brought one down because you'll never forget it when you wear it.
just
So,
looking at it.
so time and pressure. This is I'm a guy, I like pictures, this is how I do BiPAP. So, What are our normal BiPAP settings?
12/6.
Yeah, see, she knows. That's exactly what it is. It's 12. You're like, wait a minute, 12/6. I don't know where it came from, but we just do it that way. You're exactly right, 12/6. So, what do you want on? 12/6. Sounds really important, but so anyway, this is all 12/6 is. Pressure at 12, pressure at 6. Now go along like this. And come down. This is pressure over time. So this little dude right here is a trigger. So they start a breath. The machine's like, oh, they're starting a breath, and it gives them more pressure up to 12. 12/6, and the 6 is the bottom number. Just to keep it basic for you, just to keep it so not too much information at once. Let's put this patient on 12/6. Okay, so we've got the 6 is the oxygen component, the 12 is the CO2 or the ventilation component. So when I say ventilation, you automatically think CO2. Oxygenation is pretty easy. O2, SpO2, all that kind of stuff. Ventilation, CO2. Okay, so we got him on BiPAP, 12/6. Jimmy, I need a blood gas in an hour. Blood gas. 7.33, 56, 110, and 29. So 1 hour blood gas after we did the BiPAP, 12/6. This is our new one. Without writing everything down, what is that blood gas? Acidosis. Respiratory. Are we getting help? Yes, but not enough. Partially compensated respiratory acidosis. So we're still in respiratory acidosis. We're not to where we really need to be. Because we know that if we're at 7, if we're at normal pH, we can stop. So now we're at 12/6. So you're going to say, we'll call this the doctor, and then the RT will probably make this change already. 2 things that affect somebody's CO2. I said it earlier. Respiratory rate and tidal volume. That's what affects their CO2. So in this case, I'm not going to turn the rate up. We do that on a ventilator. So if Chris was on a BiPAP and I would go in and say, well, you're breathing at 20 right now, I'm going to change it to 24. Now, there's some pulmonologists than that. All it's going to do is fluctuate more and be out of sync with you. So we want to increase the tidal volume. So what we would do, we're not going to do respiratory rate in this case, we're going to do tidal volume. So we're going to take our 12, increase it to 14. So now 14/6. Now our little pressure waveform looks like this. 12, 6, 14. It's going along, triggers. These peaks are taller than these peaks were. In other words, it's helping their breath each time. More going in. This will decrease their CO2 because we're ventilating them more. Each time. Am I worried about the 110? Probably not. I just need to adjust my FiO2. But we would change that and make that a big space where it's going up and down. So BiPAP's great for that because we can change these 2 numbers to affect oxygenation and ventilation. If they're both really bad, oxygenation and ventilation, like let's say this was like 50, and we had them on a lot of oxygen, we would probably change it to 4. We would raise both of them because remember this bottom one affects O2. We raise the bottom one up and you put a cannula on somebody, I'm probably making you question everything you do. Because I know you guys know this. You're like, oh gosh, I don't want to answer this wrong. It can go up to 6 liters per minute, a standard nasal cannula. But the thing that's funky now is we got these green cannulas around that go to 15, right? And you're like, what the heck is that thing? It's kind of a middle range. We're not going to talk about it in your test, but we call it high flow, and then we have a high flow heated, but the high flow nasal cannula goes from 1 to 15 liters per minute. And they have something called a high flow to heated nasal cannula, which you might have seen before. It goes up to 60. This is the deal. When you're giving somebody oxygen, this is, you can give them about up to 44% with 6 liters. So there's a calculation for it, 4% for every liter, 44%. So the air we breathe is what percentage of oxygen? 21. So we can get up to about 44% or so with a regular nasal cannula. So we start there, and then if they need more, we go to high flow. The difference is this 6 to 15 liters, this kind of gap in here on high flow, it's variable, and we're really only going to be delivering maybe up to 70 more percent. Don't really deliver 100% oxygen because of just so much mixing of air. So we can get up to about 70-ish percent, and these are ballpark figures, but they won't ask you this specifically. Only about 70% with a high flow cannula. So with this patient, blood gas is normal, PaO2 is low. You also kind of would like to know a SAT. So let's say that SpO2 is 90%. Okay. There's no history of lung disorder or anything like that. So in this case, what might you put on? Nasal. And what would you start them at? 2 liters. Okay, 2 liters. Now, in nursing school, I'm not sure how long you're told to wait before you assess. We know it's 5 minutes. If they're breathing normal, 5 minutes, their SAT should come up to where it's going to be and stabilize. So wait 5 minutes, and we can always titrate that and titrate it for the saturation. So the oxygenation part is pretty easy. If they start, so why would you ever have to worry about using a Venturi mask? You're like, oh gosh, RT Kim said there's a Venturi mask. I don't want to use it. So the cool thing about Venturi mask is, and it's just good to know about, and Venturi mask is my #1 viewed video throughout the world for me. That and trace. Because Venturi masks are just so weird. So I've got tons of views on Venturi mask, and the thing you gotta know about Venturi mask that's most important, exact FiO2 or exact oxygen percentage. So I can give you exactly the one that I want to give you by those little colored pieces. So I give you exactly this, exactly this, exactly this. With the cannula, this is all kind of a guess. Now, what patient will we want to give exact FiO2s to? Or we're kind of most worried about, like giving them too much oxygen. COPD. Okay, so there is, I don't want to get in the whole hypoxic drive theory. I believe it's true, I don't believe it's a theory, but we want to limit the excess oxygen with them. Okay, but I really think over the next couple of years, we're going to be limiting excess oxygen with everybody. I totally believe that they're going to be like, we're coding somebody and we'll be like, get them back and we'll automatically start weaning oxygen. Because they found there's just so much giving people extra oxygen that can cause damage, even for a short amount of time. We were talking about this with EMS and Clinton the other day. He was like, I think we need to start weaning oxygen. And EMS is like, put an on and breathe on and get them here. But they have a long transport in Park County, so it's like 30 minutes. Like, maybe we need to start weaning oxygen because there's just a lot of stuff we're starting to wean oxygen to only give somebody how much they need, not no excess at it. So, Venturi mask, exact FiO2s, probably for a COPD patient. That's all you really need to know about it. It goes up to 50%, but it gives exact FiO2s. Non-rebreather, you've probably seen it, has a mask on it, got a couple valves. We say this delivers 100%, and you can say it too, it doesn't actually, but if they need a lot of oxygen via mask, non-rebreather is the way to go. So we have our cannula, a little bit worse, high flow nasal cannula, a little bit worse, Venturi mask, it's kind of for COPD, and if we're just like, we need to put oxygen on them now to get them out of here or tube them, non-rebreather. So if they're doing that bad, we put a non-rebreather on, they'll probably be tubed soon. So, all right, so nobody should be on a non-rebreather continuously, because that means they're not able to maintain. So, all right. A couple things so those are all different kind of oxygen devices. Managing a patient with continuous pulse ox, do you have any problems with that? That's pretty straightforward. Why, do you guys know why a person might have a pulse ox on at night, throughout the night for like a print off? Yes. Actually, a lot of times, first thing we gotta do is qualify for oxygen, and then we try to qualify for CPAP, but we're looking for a saturation of 88 or below for 5 minutes total throughout the night. That's what Medicare says. So it can have a 1 minute, a 1 minute, 1 minute, as in the 5 minutes, usually people, and that gets them the first level, which is oxygen. Okay, so that's why we do those print-offs throughout the night. Be something to think about on your patient. We just need to have that. I think it's got to be at least 5 hours of a study. Continuous end-tidal CO2. Now, why would we ever do end-tidal CO2 on somebody continuously? Why do we do it now? We don't do it a lot now. We used to do it a bunch.
Like epidurals and stuff.
Yeah, so PCAs, which we don't really have anymore, and epidurals, we had capnography on them. Now, Vita knows, what did we use before we had capnography? Before, if we had a PCA patient, they had to have what on their finger? A pulse ox. So it's good to know the difference between these two. Pulse ox, so SpO2, and I call it EtCO2, or end-tidal CO2. That's just oxygen. That's oxygen ventilation. So which one are we going to measure? Which one's more important? Nice. 'Cause it's number one. It's exactly right. You guys just know way more than everybody else by saying that. So I almost can give you a bestowed respiratory degree for that. This is more important because they have to ventilate before they can oxygenate. So have any of you guys worked nights before and put a pulse ox on your finger and tried to get it to go down? Yeah, I mean, we all have. We all have. Put it on. We've done it. You know, if you bagel yourself, you can get your heart rate go down. Have you done that too? That's the next level. So, can you get it to go down? No, it's super hard.
Yeah.
It's really hard for somebody with normal lungs to get your pulse ox to go down, even hold your breath. I mean, you can get it to go down like 1 or 2 points, but usually you go like this, and you just recruit a bunch of alveoli, and your stack goes up. So that's usually what people do. It's kind of funny. So it's really hard to get your sat to go down. So when we had a pulse ox on somebody and our PCA, pulse ox be normal. Their breathing would slow down, and when their pulse ox would go off, they were near code. Because when for your pulse ox to drop, you really have to be. You can. I do a thing with the new hires. I have somebody hold their breath for 30 seconds, which is kind of hard to do. 30 seconds holding your breath. We watch a pulse ox. We watch their end-tidal CO2. End-tidal CO2 alarms at 30 seconds. They're not breathing. Pulse ox never changes. And that's the reason why. Somebody goes apneic, their pulse ox takes a long time to get down. And by the time it gets down to like 80 and 88 starts to alarm, you better get there quick because they have been down. Probably a couple minutes actually. Probably haven't breathed. Especially if you have a little supplemental oxygen on them. If they had 2 liters on them, they could last a while. We do that with brain function for patients who have no respiratory rate. When we're going to check them to see if we can harvest their organs. We actually take the endotracheal tube, cut off an oxygen tube. We stick a little oxygen tube down, turn it up about 6 or 8 liters, take them off the ventilator, and they do not breathe. And I don't know how long the test is. Do you ever part of those? Mm-hmm. So usually it's 10 minutes. Take them off. They don't breathe. It's essentially a dead body for 10 minutes. Guess what? As long as their heart's beating, they still got a pulse ox. Because you're pumping that oxygen into their lungs and flowing it through. It's actually diffusing across and getting to their system. So oxygenation is a very late sign. So always, if you got anybody, think about this with if they're patients that you're looking at, post-op, PCA, that type of stuff, capnography is really important. That's when you measure their respiratory rate. It will alarm before pulse ox does. Continuous pulse ox is good if we're going to qualify them for oxygen or something like that. End-tidal CO2 is good, post-op, or they're getting pain medicine. A couple different questions that I had was about chest x-rays. So do you guys read through chest x-rays? So let me give you this one question that I thought was really interesting. So you have a patient who has pneumonia, and what would you suspect to be on their chest x-ray? Like what the physician would write. Let me give you the options. Cavitation, diffuse patches, a pleural effusion, or consolidation. Consolidation. Good. And that will kind of lead into the next one, consolidation. So we read through those. Cavitation. If you hear cavitation on chest x-ray, what do you think? There's 3 things that go off in my head when I hear cavitation. Acid fast, TB. So that's how it relates up to in my brain. I'm like, I hear one like Josh said about TB. When I hear TB, I think airborne, acid fast, cavitation. Those are the 4 different things that all kind of go together with it. Just keywords they'll put in there. So cavitation, definitely not it. Diffuse patches. What could diffuse patches be? A lot of stuff. But pneumonia is usually a unilung or a located thing. It's not usually throughout. Diffuse patches could be ARDS because they're all over, or it could be fluid, or it could be something like that. But usually pneumonia is located in one specific area. Breath sounds for pneumonia. What might you hear?
Diminished.
Diminished, but we got a lot of diminished breath sounds around here. What might you hear with the pneumonia?
Diminished in a certain area.
Yes, diminished in a certain area. Yeah, so let's talk about them real quick because that's actually on there too. Some breath sound stuff. So breath sounds. Let me give you the Jimmy rundown of breath sounds, and I know that it is very, very subjective because subjective or objective?
Subjective.
Subjective. It can change wherever it goes. For some reason, I can never figure those out. Okay, so. Here's the 5 ones that I use. Okay, so sometimes I use diminished. I like to use other things with them, but diminished is very general. It's usually like, I turn my stethoscope head around the right way, stuff like that. I probably just didn't get a chance to listen to them. So it's a way to kind of cover yourself, Well, they're weak and terribly. They're diminished from. I know. I come from the same stock, so I know how it is. But this is the breath sounds. So I'll give you an idea of what each of these things mean. So do you know what bronchi are? What would you call? How would you describe bronchi if you're listening to this?
As per Jane Fry, who used to work on PCU.
Yeah.
Ringer washing machine noises in chest. That's what she used to describe bronchi as. Like ringer washing machine. That big.
Okay. Yeah.
Okay, that's how she used to describe.
Can be. Yeah. That's also coarse breath sounds. That's kind of a coarse thing. This is the way I think of bronchi. This is mucus that moves. So if you want to get cool into breath sounds, you hear something, listen to Chris's right upper lobe, and I hear this low pitched, like something moving in there. Mucus, I think. So this is what I do. I set the scope on, leave it right in the same spot, take the thing out of my ear, and say, "Can you cough hard one time for me?" They cough, put it back in, said breathe now. If the pitch changed, it moved. So I call that bronchi. So that's mucus that moves. Coarse is really kind of hard, but all these things have to do with pneumonia. So if they're in one specific area, it can be pneumonia. We know on the ventilator they can get coarse breath sounds with ARDS because of what stage they're in. It's fluid. Sounds really bad. And they're not going to cough and it's not going to sound different. But bronchi is mucus that moves. Crackles is usually end expiratory, and it is just the alveoli going, opening up right at the end. So it's like, right at end expiratory in most cases. So you have all these alveoli collapsed, non-functional, and they take a full breath in and it goes and opens them up. Crackles can be pneumonia too if it's in a certain area, but if it's gravity dependent, it's probably what? So if they're sitting in the bed and you're listening to their back and you only hear in the lower lobes, the bases, what do you think the crackles are? Fluid, absolutely. CHF. So it's just a little bit of fluid. So you hear the crackles and the bases. Now, the same patient, let's say they lay down and go to sleep on their right side, you come in 30 minutes later, you're just really into breath sounds that day. You listen to that right side and you're like, now I hear it all the way up the right side. Because they're gravity dependent, it's fluid, it moves like that. And that's where it's kind of located. It's all about ventilation perfusion. So, crackles, those fine crackles, usually fluid, especially when they're gravity dependent. Diminished is kind of a hard one. It's like I can't hear much, so I tried to get something. I rarely put just diminished. I'd rather put clear because I just don't hear anything. So I don't hear adventitious breath sounds. That's what they use they were talking about adventitious breath sounds, but that just means breath sounds that aren't normal. Wheezes are a little different. Now wheezes, are on expiratory in most cases. So you have, this is the progression of wheezes. I bet you guys have all seen. So what wheezes are is the airways are not, the alveoli are not collapsed off usually. It's just the airways are small. And the air is just squeaking through it, and it's going as it squeaks through it. So a lot of times we'll go in the morning, give them their breathing treatment, and you listen to them, and you're like, they're diminished, clear, whatever. Give them a breathing treatment, now they're like, and you hear all this wheezing now because when they were diminished, they weren't moving air. And we just opened it up enough for them to wheeze. And that feels good to them because it opened them up enough. So wheezes, there's different ways to do it. First of all, number one is not bad. End expiratory wheeze. And we can almost do this to ourselves. So wheeze, just think when your airways are they're kind of dynamic. So what you can do is when you take a breath in, they get bigger. When you exhale, they get smaller. Well, if you go, that's kind of upper airway. But if I go down and press really hard, I'm closing these airways down as far as I can go and then squeak air through it. You can do that when you fully exhale. End expiratory wheezes is kind of the first level. If they have end expiratory wheezes, all right, not a huge deal. All right, we can treat that. We usually can do so. They're breathing, but if you have them blow all the way out, then they start wheezing here at the end, which means, yeah, they probably got some bronchospasm, pretty easy to fix. You guys know this stuff? Expiratory wheezes, this kind of progression. Expiratory wheezes is the next one. So this is, as soon as they start to exhale, you hear wheezes. Okay, so that's the full expiratory. So they're getting a little bit worse. And then INE wheezes. So that's kind of bad because when you're taking your breath in, your airways should be getting bigger. And when they're not, when your airways are supposed to be getting bigger and you're still wheezing, that means you're really, really tight. So if you have somebody that progresses through this, their airways are getting tighter and tighter. Even if they're getting breathing treatments, they should not. If they get breathing treatments with this, it should go to this, and then it should go to this, and then it should go to clear. Or go to this and they feel better. If they had expiratory, you give them breathing treatment, they should go to this, and then they should go to clear. Now, if they were diminished, they could go anywhere on this and go down. But this should be the progression from 3 towards 1, looking at like 3 would be the worst of the breath sounds. Primary pulmonary hypertension. So another question that I saw was really a little difficult. It says, which one of these diseases could cause primary pulmonary hypertension? So it gave a few. It gave COPD, it gave Raynaud's syndrome, sickle cell. Actually, sorry, start this again. Which one of these is not a diagnosis, for primary pulmonary hypertension? Okay, so not primary pulmonary hypertension. Pulmonary embolus, sickle cell, Raynaud's, or COPD. This was a hard question for me. What'd you say?
PE.
So PE could cause pulmonary hypertension.
Primary pulmonary hypertension.
Yes. Yeah, so it's kind of jacked with me a little bit too. Raynaud's, everybody knows what Raynaud's is, vascular is closing off a little bit. That can be primary pulmonary hypertension. This is a test question from this thing. The sickle cell could be too. COPD was not. They said COPD is not primary, it could be secondary. So it's secondary to the obstruction lung disorder is pulmonary hypertension. Think about that a little bit. That one kind of jacked with me a little bit. That is the correct answer because I went through and made sure they're all correct. You have a COPD patient. They give you 4 different meds, and they say which one of these treatments is probably not something you're doing for them. We have analgesic medications, oxygen, steroids, and bronchodilators. Which one would it not be for this patient? And then why?
Are they on oxygen before?
Nope. So they don't give you a lot of, that's the thing, you can't really dive into it much. You have a patient that has COPD as a history. Here's 4 things they could be on. Which one is likely not to be something that they would be on? analgesic. It is. So steroids, we know that. Inflammation fixes it. Oxygen, bronchodilators, none of that. What do analgesics do? Okay, so we have our COPD patient. We know with chronic obstructive pulmonary disorder, they've got ventilation problems. Okay, what would be the problem with giving a lot of analgesic medications to a COPD patient over giving analgesics to us?
Respiratory dysfunction.
There you go, respiratory depression. And so any, like you think of analgesics as respiratory, it could be respiratory depression. So that's where you probably wouldn't give it, although you can, we do, and they can tolerate a lot sometimes. But it's just something to think about the analgesic medication. Because you hear COPD, you think they might have ventilatory issues. We don't want to slow their breathing down. Okay, so kind of think about that when you see that COPD patient. Almost every one of these had that situation. Another one was which one of these things is not used to assist in the diagnosis of COPD? Assist in not the diagnosis. Assist in the, it wouldn't be diagnosis, but progression of the disease. Okay, so which one of these four things would you probably not look at? This one blew my mind when I heard this one too. BMI, spirometry, functional dyspnea, or a chest x-ray. BMI, spirometry, functional dyspnea, or a chest x-ray. Which one of those would you not look at for COPD, for progression of COPD? That's tough. Chest x-ray. It was kind of because I was like, well, wouldn't you want to see bigger AP diameter and stuff like that? No, the other three are more important. The BMI, because that's going to show when they're working so hard to breathe, they're going to start using up all their extra stores, and they start getting frail towards the end. Spirometry is always used. You always can tell where they're at by doing a spirometry. Functional dyspnea is some scores that we do, like for pulmonary rehab. We have them come in and ask everybody every day how short of breath you are on 1 to 10 scale, and every day we document that. Yeah, how short of breath are you on 1 to 10 scale? How short of breath? I mean, so we have this functional dyspnea thing where every day we look at this and trend it, and we want to look that they're coming in by the end of the program with less dyspnea when they walk in. That's kind of our goal. But so functional dyspnea. So chest X-ray was the one that's not used. So that was a little tough question. And then one more thing was with the lungs, pleural versus inside of the lumen of the airway. So, and chest X-rays. So this was one too. It was kind of funky. Did you get one of the tracheal shift ones?
What's that?
Tracheal shift. Did you get a tracheal shift question? So, do you guys know much about tracheal shift? So tracheal shift's really cool from the outside because you can tell by if their trachea shifts where their problem is. So this is the lung tissue, and right there is the pleural space. Okay, it's usually negative pressure. It's very slides, really easy. It's made of this. So, and they have their trachea is right here. They give this one. Patient presents with a pneumothorax. On the patient's having shortness of breath. Patient has diminished lung sounds on the right side. Which way do you suspect that their trachea may be shifted? It's kind of tough.
Toward the right?
Nope. Away. So let me tell you how to know this. Anything that is, and they do this in respiratory therapists all the time. This is kind of a cool assessment tool. Anything in the pleural, any pleural issue, trachea goes away. Is pneumothorax, pleural issue, right? Pneumonia is an intralung issue, parenchymal space issue. Trachea goes towards it, shifts towards it. So if it's a problem inside the lung, the trachea goes towards it. If it's in the pleural space, it goes away. Next one. Pleural fusion. Trachea goes away or towards? Away. Check that if you have somebody with big pleural fusion. Most people are. It's part of your assessment. just to feel where this trachea is. Just kind of feel it. It will, it'll move. And it will be over farther. When they fix our pleural effusion, it'll come back to center. I look at the two weird things I look at on somebody when I walk in the room. I look at their clavicles. I hope people don't think I'm a pervert or something. I look at their clavicles. I like looking at their neck for trach scars, first of all. Did them in trach before. And then their clavicles for chest excursion. And you can tell a lot about the way somebody's breathing or where their trachea is of what's their current respiratory health almost. So I like looking at tracheal. You want that trachea is supposed to be lying directly up. And in most cases it is. But if you have a pleural issue, it will go away from it. And you actually can see it, but you can definitely feel it. It's over to the side. So if it's a lung issue, like a big pneumonia on the right, the trachea will go towards it. If it's a pleural issue, any type. So let's say you have a tumor in your pleural space on the right. Trachea, left. Pleural space issues goes away. Interlung or parenchymal issues, it goes towards. So something to think about, just a little thing in the back of your head in case you get one of those, like, they give you the pneumothorax problem and you're looking at it and you're like, okay, pneumothorax, pleural issue, this trachea should be going away from that dude. Okay, they should not have breath sounds on this side, trachea away. They also did give, what's the number one treatment for when, so they have a pneumothorax, which is bad. Then you have a tension pneumothorax. So what's the difference between them? If you were taking care of somebody and they had a pneumothorax, what would make you start to think that it turned into a tension pneumothorax? It's a big difference, because when they say, it's just like in those NCLEX tests, when they say marked change or copious amounts, those are all things you're like, I need to turn on my ears right now because they're telling me something. Marked change, copious amounts, they're trying to tell you this isn't like just your normal day stuff. This is something you need to take care of. So using those descriptive words, if somebody says tension pneumothorax, that's something that's got to be fixed right now. So tension pneumothorax, you're actually starting to get your mediastinum and everything starting to shift, and they're getting outward signs, blood pressure, hemodynamic instability, that kind of stuff. So patient has a 10% pneumothorax. Yeah, not a huge deal. But if they say you're taking care of a patient with 10% pneumothorax and their blood pressure begins to drop, slowly begins to drop, you're going to start thinking that's a tension pneumothorax. So tension is just like putting the word marked or copious in there. So it needs to be fixed right now. This isn't like, we're going to call down IR and see if they're ready for us to get in. Work is staying at the end of the day type of thing. No, tension pneumothorax got to be fixed right now. So how do you fix that? This was a question. Chest tube is good, but not necessarily with a tension pneumothorax. You probably need to set it for a chest tube, but that's going to take a little bit. You agree with this? Needle decompression? So it's needle decompression. Yeah. So, third intercostal space, mid-clavicular line, that stuff they're not going to really get you on, but those are things you go over instead of under the rib, because under the ribs where you have all the nerves and other stuff, so you go over the rib, but you're not going to, it's going to be either side, but it's going to be a needle decompression. Because at that point, you don't have time to wait, because they're going to code before you probably can get everything set up for a chest tube. So to do that. Now, I've never had to do it. I've seen it done multiple times. I've seen it done when it wasn't the problem, which was kind of interesting. So, really cool story. Evansville, ICU, they were rock star pulmonologists. We had good ones here. They were young guys, and I was brand new RT student. I was stuck between the vent. Patient was decompensating. Pulmonologist was here, and I was listening, and I was listening, and the patient was doing terrible. We were bagging him, and he goes, "What do you hear?" And I go, "I just don't hear my breath sounds on the right." And he goes, "Okay." And I was like, what? What did you just do, man? I mean, I'm a student, right? What are you sticking that needle in there for? It wasn't the problem. And I felt like, but he was like, "That's okay, just get chest tube in now." So maybe he was showing off, but it was like one of those things you're like, oh gosh, every bit of assessment makes the difference now. I'm just not really hearing on her. Might be a mucus plug. I don't know, maybe it's not a lung guy. But anyway, that's the fix for you do get pressure, you split a chest tube and it fixes it. But it's a quick fix for the tension pneumothorax. So you see a question with that, just think I need immediate intervention because they're going to code it. Let's see. Pleural space issues, tracheal shift, pneumonia versus pneumothorax. Yeah, that's good. Management of patients requiring tracheostomy tubes. So, I don't really know what they could ask with this. They're probably not going to get real technical. Okay, a couple things about trachs that are really important is that since if you're breathing with a tracheostomy and you're breathing from here to here, you're bypassing all this area, and that means you're bypassing the heating and humidification of your air. So we like to have moisture on somebody if they're doing that. Your air, by the time it gets to your carina, your body does this whatever way it can. By the time it gets to your carina, the split, 37 degrees, 100% saturated with water. That's what it wants. It wants it warm, and it wants it saturated with water. And all of this area does that for you. It warms it, saturates with water. Problem is, once you put the hole here, you only have this space to get there to do this. So what does your body naturally do? It pulls moisture from your airways, and surrounding your airways is mucus. That's why the trach patients have the nice, tenacious, stick on the wall type of mucus because their body's pulling moisture. It's pulling moisture from their body to try to get this stuff warmed up and moist by the time it gets to this aspect right here. So that's why you have thick, nasty secretions and they come up they can hang off the wall. So we try to give them some type of heat. First of all, humidity. Heat and humidity is really key. And it really takes a lot of work off the body, okay? So when they become dehydrated, you immediately tell it in their mucus. And their mucus gets really hard and they get mucus plugs and those type of things. The other thing with a trach, I don't know if they would ask this, but two things that I look at when I come in to see a trach each day. Okay, is it a cuffed trach or an uncuffed trach? Okay, so is there a little pilot balloon hanging off or not? It's really important. If a pilot balloon is hanging off, then I can use it in an emergency. I can seal it up and use a bag on it. If it is uncuffed and there's no pilot balloon hanging off, it's essentially just, there's their airway, it's just a tube sitting in their airway. That is my alarm. Man, I hate that sound. Oh gosh. Snooze, 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 snooze. So if it's uncuffed, it's essentially just a tube sitting in here. So if I put a bag valve mask on this and squeeze it, the air is going to always come out the top. Path of least resistance. If it's a cuffed trach, I can seal this off and the air goes down to the lungs each time. So that's the difference. But I can't think of, you could get really deep with this, but I can't think of any other situations. Now, if they have a cuffed trach and they're having, let's say they're having aspiration issues, you're probably going to have an inflated cuff. When you inflate the cuff, air does not go up. It comes in and out of this tube. Because if they're aspirating, you don't want that to get in their lungs, so you want it to stay here. So they will not be able to speak when the cuff's inflated. Okay? So, because their vocal cords are up here. Vocal cords up above so the only way to get to speak is to get air to go past your vocal cords, and you can't do that unless you have an uncuffed trach or a deflated cuff. I can't really think. We commonly use a trach mask, which is sometimes a Venturi mask or an aerosol of some type to give them oxygen over there. So if you pick two places, you're going to pick to go here. Now, if they have a tracheal button, which is, it's an uncuffed trach and it has a little red cap over it. So during the day, they breathe through their mouth normally, and maybe if they have really bad sleep apnea and they didn't like a CPAP, they got a trach for it. There's a couple guys that have that. Can imagine. And so they open this up at night and sleep. So, in most cases, if somebody's having difficulty, we make sure that they have the best airway they can. So we will take anything out of the way, if it's a speaking valve or anything like that, and try to make sure that they don't have any problems with that. Any other questions you guys might have? That was a ton of stuff. you wanna go over a couple things? I've got 5 more minutes, we can do more blood gases. Josh, anything that you else think, I know I can really fill them out of time with speaking.
I mean, no, we can't do
Different
everything that was on the test that I took, and like I said, I'll get you guys a copy of this, I'll email you guys today, just so you can have the test plan. Cause it literally will tell you everything you need to know. Cause before I looked at the test plan, I was studying stuff on renal that I did not need to be studying. And I actually looked at the test plan and I was like, well, I just wasted 10 hours of my time doing that. And they won't ask you anything that's not on.
Stable in the body system, but
Let me give you just a quick, these are like just keywords. So for these 3 respiratory diseases. So if you're, and I know I had an asthmatic on there too. So ARDS, so things you want to think about the ARDS. It's inflammation through all the lungs. It's usually throughout the body, but it's through all the lungs, and it's usually when they're on a ventilator. Okay? So it's usually when they're on a ventilator, it's ARDS. They're going to have abrupt decrease in their oxygen. And they're going to coarse breath sounds, and there's many stages of ARDS, but I mean, it's really pretty bad. So usually they're going to need a mechanical ventilator for that. Asthma, I know status asthmaticus was brought up multiple times, a couple times on my test. So you can have an asthma exacerbation, but if you're in status asthmaticus, that means you're really closed down. So treatment for that would be bronchodilators, and you could give subcutaneous epi. You're treated very similar to like a allergic reaction. Is what you're going to do. And we could also give magnesium, smooth muscle relaxant, and if you can't get it fixed, you're going to put them on a ventilator. Status asthmaticus is kind of like saying they have asthma versus having pneumothorax and intention pneumothorax. Status asthmaticus, they're doing pretty bad right now. COPD exacerbation, so they have COPD, but they're not ventilating well. That's almost every COPD patient we have coming in here. They're having an exacerbation. Usually it can be turned around. Steroids, bronchodilators, fluids, antibiotics if needed. So those are those different ones there. Now, one last thing. So we have our ARDS patient, which might be on a vent. So let's go back to our blood gas real quick. And I'm just going to tell you a couple things to change because I did miss this part. Okay, so all this stuff's gone. So just a real quick, how to run a vent in 2 minutes. So mechanical ventilation, they're probably not going to get real crazy into like all the different modes and whatnot. So you're probably going to have assist, control. You may have, we're just going to say assist control. That's probably going to be your main one. What this is, assist control, if I put you on a ventilator, select your own pictures, time and pressure. So, and I'm going to have a couple settings. I'm going to have a respiratory rate setting. What's normal respiratory rate? 12 to 20. So on the ventilator, it's really close to the same. It's really close. We sometimes go down to 10, but let's just say 12 to 14 somewhere. Tidal volume. So how much volume do you need for somebody? Technically, we want 10 milliliters per kilogram ideal body weight. Most people, not that they'll get milliliters. 500, 600, 700 milliliters. Kind of ballpark. The taller you are, the more tidal volume you have. Your actual weight does not matter. It's your height. Usually start at 5 apiece. So these are our settings, and then our FiO2. Let's say we start at 50% oxygen. So this guy right here, CO2. This guy right here, CO2. This guy right here is oxygen. This guy right here is oxygen. So that's what we're going to change to help with those things. So if I have a blood gas like this, my blood gas, what's likely gonna be something I'm gonna change to help this patient? FiO2 or PEEP, because it's an oxygen issue in this case. Cool. So if you're all 50, you may go up to 60. They're not gonna get real technical with it. And I'm probably not gonna even talk about PEEP. They're gonna say, I'm gonna turn up the oxygen. What might I change in this case?
Both. You'll do probably the volume, tidal volume, and the O2.
Could do O2, 80s we kind of consider as normal, but so this is, like you were saying, this is a CO2 problem or a ventilation problem. I'm gonna pick one of these guys. I don't think they're gonna get real technical. Respiratory rate actually, if you change the respiratory rate, it changes it faster than the tidal volume does. In respiratory school, we have to calculate which one, so I'd probably go up on a respiratory rate with this one. Okay? So that's good. So let's go to the next one. Since you can read the blood gases, that helps a lot. Okay, FiO2, you're on FiO2 of 50. Which one do you change first? Which one do you change second? So if you can only make one change, what would you make? What would you fix first? Good. So you're going to change your respiratory rate first, and then you probably right after that you're going to change FiO2, or you could change your PEEP, but your FiO2 for your oxygen. Remember, ventilation is always treated first. So the ventilation aspect, but usually if you start ventilating it more, this is going to come up. This is easy. You change their FiO2 and you titrate to their saturation. PaO2 is just dissolved oxygen floating around the blood. It's like your reserve. Your most important number is your SpO2 that's actually bound to it. In the only case it's not bound is carbon monoxide, which I don't think that'll come to you guys. So anyway, go after the ventilation problem first. The ventilation is going to be respiratory rate or tidal volume. And then the oxygen will probably be PEEP or FiO2, probably just FiO2. So if you want to memorize two, do respiratory rate and FiO2. And that's the gist of a mechanical ventilator. I mean, I don't think that they'll get too technical with this. If they ever start having difficulty on a mechanical ventilator, and mechanical ventilator's alarming, and the patient is not tolerating well, you always take them off and manually ventilate. I don't know if that would be on there either, but it's kind of like your fallback. If you're not sure what's going on, don't jack with the vent or change stuff on the vent. Just go and manually ventilate, because it doesn't just, it just goes in, takes the whole equipment aspect out of it, just goes in, plus you get tactile feedback like, ooh, I mean, is it kind of like not bag? Is there something in there? Or are they real wheezy, or they got a lot of other kind of secretions and whatnot, but that's kind of the fallback.
They could possibly get like basically alarms. So
Yeah.
like it's alarming and they're biting the tube, like those kind of obstruction kind of
Yeah.
things maybe, but I mean it's very basic ventilator.
Yep, so.
Nothing too crazy, not looking for, any, like should you prone this patient or anything
Yeah.
crazy like that.
Yeah.
Just basic, blood gases, and then like working through some of those basic alarms.
So what high pressure alarm on a ventilator means it's taking more pressure to get the air in than it should. So what could cause a high pressure alarm? Somebody cough, pressure alarm. They bite the tube, it can be a pressure alarm. They're fighting and whatnot, or they could have a mucus plug too. So you have to go in and you have to assess that to see what the problem is. But a good way to assess if they are in extremis is to take them off and manually ventilate them in those cases. So.
Pretty much assess all your vent alarms by using the DOPE mnemonic that we
That's
do in
right.
PALS.
Yes. Displacement, obstruction,
Pneumo, and
pneumo,
equipment.
or equipment. Yep. Dope mnemonic. That's really good. That's right on. Anything else you guys have?
What was the E in DOPE?
Equipment.
Equipment.
So that's where you would take them off. So you assess for dislodgement or displacement. So did they like pull the tube out? Is the tube still in the right position? obstruction, like Jimmy said, are they biting the tube, coughing, those types of things? Do they have a pneumo? Because PEEP, when we're mechanically ventilating someone, can cause a pneumothorax. Very rarely, but it can. We've seen it happen. And then the last one is equipment, so which is where you take them off the vent and bag them manually to see if the ventilator itself is the problem.
Yeah, that's really a great mnemonic for that. And then if they do have a pneumo on the right, which way is their trachea gonna go? Nice job. That's exactly the right answer. Okay, cool. Anything else? All right, that's enough. All right, thanks, guys.
Thank you.
Yep.
Yeah.
Thanks.